So good afternoon. Today we're going to hear about global health in Mozambique. We have 6 speakers. They're 3 summer global health research assistants, Alex Peters, Alina Fomovska, and Victor Galson. And then we have Anandaraja, Sigrid Hahn, both are from the Global Health Training Program, and Michelle Sainte, who I think everyone knows, who's in MedEd as an assistant dean. Thanks.
Great. So thank you very much, Erica. We're grateful for the opportunity to be able to tell you about global health and especially about the Mozambique project. So my job is just to give you the background so that you have some understanding about how global health education fits into the global health structure at Mount Sinai overall and how the Mozambique project fits in within that. So Mount Sinai Global Health, our mission is to close the unconscionable gap in global health in 4 ways. We call these the 4 pillars of global health at Mount Sinai: training healthcare workers, researching effective solutions, providing direct patient care, and advancing human rights. And so we'll be focusing in on the training portion of that as it's most relevant, A, to our project, and B, to this crowd. Global health at Mount Sinai in the most recent future started with an Office of Global Health within the Department of Medical Education. Okay. Thought I was getting a signal. So we started back in 2005. We were founded by David Muller and Ramon Murphy, who put together this Office of Global Health, and our aim at that point was to provide educational global health opportunities to medical students and residents. But very quickly from that point onwards, the interest in global health and the demand for global health education grew, and we expanded to encompass not only the medical school and a number of the clinical residency programs, but also the MPH program and a number of the research institutes. So just a couple of years ago, this became our structure. Phil Landrigan became the Dean of Global Health at Mount Sinai, Jagat Narula the Associate Dean. David Muller is still heavily involved, and we still regard our home as being in Med-Ed, although we are now kind of straddling Med-Ed and Prev-Med. And then we've developed these into these 4 pillars. So from being primarily an education and training program, we've now expanded into trying to develop more heavily our research angle, the direct patient care, which was already happening as patient care missions going out of a number of clinical departments, as well as some disaster response. And the human rights aspect through the initiatives that recently Holly Atkinson has started here in conjunction with Craig Katz, including Survivors of Torture Clinic. So we've recruited and maybe even coerced a number of Sinai faculty into joining our ranks. So we have quite a number now of global health faculty who put their time into developing educational curricula and mentoring our students, and then a number of brave souls who step up specifically to mentor students at every level and residents towards research projects, public health projects, and educational projects with our partner sites, which I'll talk more about in just a second. So just to give you an idea about the context, our medical student global health training initiative does not stand alone. We also have global health tracks within the MPH program, so a concentration in global health. We have global health tracks within several clinical residents, including peds, internal medicine, emergency medicine, psychiatry, OBGYN, and we have just developed a global health fellowship program, and actually Ben sitting back there is our inaugural global health fellow. We're just recruiting for our 2nd global health teaching fellow. So for our medical students here who are going through a global health training and are actually interested in taking this further into their career and into advanced training, those advanced training opportunities exist here at Mount Sinai for them to step into. For the medical students themselves, we have offerings at throughout all 4 years. In first year, our kind of seminal offering is the Summer Global Health Project. To prepare them for the Summer Global Health Project, we offer a Preparation for Global Health Fieldwork course, which is a 12-week course we offer over the winter. We also offer a career series, and the student group, Medical Students Making Impact, we now collaborate with, and they offer an alternative spring break. During 2nd year, we're mostly working with the students who have already done global health work during their 1st year to develop their project into a scholarly product, and we'll talk more about that. In third and fourth year, there's opportunities for clinical or research electives in global health. In fourth year, they can also do a 3-month Inspire Global Health project. And then between third and fourth year, we have a number of students who look to spend a year getting more immersed into a global health field work. And so they apply for global health through Doris Duke or through Fogarty, and then we also have opportunities for them to do a year at a global health site with one of our partners. And that really is to provide them with that extended period of time to do research, to implement a public health project or an educational project in an underserved community. On the right, in the white box, you'll see these are some of the other offerings that are provided by the Global Health Training Center, and that students can participate in throughout their 4 years here at Mount Sinai. And it ranges from our annual conference to training to be able to work in the Survivors of Torture Clinic here and human rights electives. So just to tell you about this new initiative, this year for the first time, with the help of Val and David, we're offering a global health medical student track. It's a competitive application. We aim to take in 2 candidates this year. They'll go into a 5-year track. They'll graduate with their MD and an MPH in global health. They'll have that extra year, scholarly year, that will be mentored and funded so they can spend a year in the field implementing a global health research public health project. So overall, over their 5 years, they'll gain 16 months of field experience. With the 2 incoming candidates, we've managed to obtain tuition for their MPH, so their MPH is covered. In the future, we hope to raise enough scholarship dollars so that they will graduate debt-free, because we know that the main barrier to our graduates actually going into a career where they can focus on underserved communities is the huge debt burden that they carry with them beyond medical school. To talk a little more about the Global Health Summer projects leading into the Mozambique project, our summer projects are competitive. Our MS1 class hears about the summer projects in the fall or the early winter of their MS1 year. Applications to get placed at one of our Global Health Summer sites go out in the early winter, and then the students are competitively selected and placed with a project and a mentor around this time of the year. Like, we've been working on this process over the last couple of weeks. So by early in the new year, they had been placed with a project site, with a mentor, and over the following few months, they start working very closely with their mentor to develop a research project, an educational project, or a public health project that they will implement in the field when they go out during the summer. They're required to spend at least 8 weeks on site during the summer working on their project. During that time, many of them will be visited in the field by their mentor from Mount Sinai. There's also a mentor on site, a local mentor that they'll be working with. When they return, they're required to submit an abstract and a poster for Student Research Day, and many of them will also go on to present at a national conference. The idea is that there's a mutual benefit here. We work very closely with our communities to ensure that the students are doing projects that are going to benefit the community, and also our students are obviously benefiting from this practical experience. It's obviously a very popular offering at Mount Sinai. When we started offering the summer projects back in 2007, we had 10 students. This year we have 41 medical students participating. Overall, since 2007, we've mentored, funded, supported 185 summer projects. A proportion of those are MPH students, but the majority are medical students. And this is where we send people. So there's a vast array of sites. Students are working with underserved organizations domestically or abroad. The focus really is on underserved, not dependent on nation or continent. The students are working with organizations that range from very grassroots, local, non-governmental organizations to major universities. So our partners vary widely in their structure. What's important for us is that we have very close relationships with the partners, and that the agenda for the students' project is decided by the community they're going into, rather than by a research or funding agenda that's decided here at Mount Sinai. And I think this gives them a very rich experience. So now I'm going to hand over to Sigrid to talk more about the Mozambique site.
So I'll give you an overview of our project in Mozambique, and then we'll turn it over to the students and Michelle Sainte, who have been there this summer. I think this is one of our most robust and exciting projects. I'm biased, of course, but that's okay. We've been working on this project. We've put a lot in the last 4 or 5 years. But it all started actually when Holly Atkinson, put us in touch with Greg Carr. Greg Carr had put together funded and founded the Carr Center for Human Rights at Harvard. And once he had completed that project, he was looking for a new endeavor. And he ended up entering into a 20-year partnership with the government of Mozambique. And the purpose of that was to try to restore Gorongosa National Park to its former glory. So this is a huge national park that's at the southern end of the Rift Valley in Africa. 50 years ago, it was considered the most biodiverse and rich ecosystem in the continent, so including South Africa, etc. But then a series of civil wars devastated the country, killed and displaced millions of people, destroyed infrastructure, but it also actually destroyed the national parks. The parks were mined, and most importantly, probably, the huge herds of animals were poached in order to fund the fighting. So the place was virtually wiped out. So the purpose of Greg's Carr collaboration with Mozambique was to restore this over the course of 2 decades. But again, with his human rights background, the idea was to pay particular attention to the needs of the incredibly rural and impoverished populations in what's called a buffer zone around the park. So there's about a 10-mile swath of land around the park. It's off the grid, it's very rural, and the people live in dire poverty. So his purpose was to reinvigorate the park, but also bring health and development initiatives to the people who live there. As I said, we've put a lot of time and energy into this over the past 4 to 5 years. I think it's one of our most robust training sites. We've sent 16 students and counting, a resident, 2 fellows, and most importantly, we have 5 local staff now, 2 full-time and 3 part-time, who we've hired and trained, and 59 local healthcare workers, and you'll hear more about this when I tell you about the project and the students tell you about their work over the summer. So it started in 2009, and as one does when one goes to a new site, the first step is getting to know the communities. So we sort of did a listening tour, basically. We did a qualitative health needs assessment, and we did focus groups in buffer zone communities that we were planning on working with. And we asked them questions, of course, about what they saw their health needs to be, but then we also asked them about what they saw the environmental and conservation issues to be, and also how they saw linkages between health and the environment. Many of the answers were what you would expect. There was a big burden of febrile illnesses and diarrhea, but I think some of the answers were pretty interesting and a bit surprising. Like when we asked what their biggest health concern was, they would say things like lack of access to grinding stones for our flour. So they saw health very holistically, because to them health is kind of everything structurally, environmentally, economically that goes into creating a livelihood for them. Another aspect that they brought up very frequently, for example, was their biggest health concern being elephant incursions into their fields from the park. So this, in one sense, is challenging because now we're talking about addressing potentially very big structural issues, but on the other hand, it gave us a good platform for creating an intervention that merges environmental conservation initiatives with health. And that, of course, is the overall goal of the restoration project. So after we gathered this baseline data, the Gorongosa Restoration Project group partnered with USAID in what's called a public-private partnership. So over the course of a year or more, worked to develop a grant. And the grant was called the EcoHealth Project. It ended up being for 3 years and $200,000. And the agreed upon goals were to work, and sorry, there are a lot of acronyms here, but to develop a community health worker project, traditional birth attendants, mobile clinics to come to these incredibly remote areas, agricultural nutrition initiatives, gender-based violence initiatives, orphan and vulnerable children initiatives, HIV workplace prevention. That's in large part because the park is a major employer of people in the area, so it's a major inroads into the community and a good place to institute health initiatives, and then develop community leadership councils. We're involved in the top 4, directly involved in the top 4 initiatives in this EcoHealth project. And this is a t-shirt from the project, and it shows you all of the partners that are involved. Sinai, of course, USAID, PEPFAR, Mozambican Ministry of Health. So there are a lot of players and a lot of moving parts to this collaboration. So 2010 was the next year that we went back and had a significant presence on the ground. And this was really where the quantitative part of the project got going. Now, I had mentioned that there's a buffer zone around the park. It's very, very rural. There are several 100,000 people living there. Looking at it, you wouldn't think anyone lives there, but then you walk among the trees and the plantations and you see tiny huts all over. But they are literally off the grid and off the map. So we had maps of the area and we have health data from the area, but we didn't have it from these specific rural villages. And because they're so far off the grid, the data that is gathered sort of regionally often doesn't reflect the reality of living in these tiny towns. So the students did an incredible job this summer. They walked house to house to house to house and literally mapped the points of every house in all of our intervention communities, which was about 2,000 households. And then they developed a large quantitative survey to gather baseline data about a whole range of health issues that might be addressed by this EcoHealth project. And we had the luxury of gathering this much data because we were on, I guess, a little bit of our own timeline. We did have grant funding, but our feet weren't held to the fire to be complete by a certain date. So to give you a sense of how long this took, they trained a local team, and data gathering, which consisted of people administering oral surveys, which were about an hour long, took over a year. And then the data analysis took data entry took another 3 to 4 months. So that's why many many projects aren't able to do this kind of baseline survey. It's a huge endeavor, but we had great success, and you'll hear more about it from the students. The next year, the project actually got rolling with the training of traditional birth attendants. And traditional birth attendants are found in many or most traditional communities. They assist with prenatal care, often births in the home, and then do some antenatal care. They're incredibly important links to the community, especially to women and children, groups that we're definitely trying to reach. But there are also things in their practices that we hope can be modernized. And one of the major issues is that the government of Mozambique now has an initiative to have births occur in facilities as opposed to the home, because it's really the only safe place to give birth. You can't predict who's going to need a C-section or transfusions. So that, among other topics, was one of the major topics that the traditional birth attendants were taught about in the training session that took place. And this was after community mobilization, reaching out to them, getting them on board, bringing them to the park, to the training center, and the culmination was a week-long training, which is the start of the rest of the initiatives that you'll hear about. So now I'll pass this over to Victor.
Hi, so in this past summer, I worked very closely analyzing the data from the EcoHealth baseline questionnaire that we just talked about, and I'll just start off by telling you guys a little bit more about it. It was long, it was 138 questions, took almost an hour to complete each time it was given, but in the end we collected data from over 11,000 individuals from these 9 very isolated communities. And with this data we really see it as a census of this population, and it for one provides a great baseline for measuring all the ongoing interventions, which you will hear more about in a couple minutes. But my project over the summer was really to take a subset of this large amount of data and present it back to the communities that we had gone into and done the survey in. So the first step for me in designing these presentations was really to consider the audience. And the main people we were talking to were these village elders, the community leaders, and for the most part they were male and had various administrative roles within the communities. But in addition to them, we also had all of the women enrolled in the traditional birth attendant program, which again you'll hear more about. And the important thing to keep in mind about this audience is that for the most part it's a mostly non-literate population. So for things like talking about a percentage of a whole, that concept really might not translate very well into their language, into their culture. And the first thing I did, or the second thing I guess, was really try to figure out which data points to present. And I kind of started with some things that jumped out at me. So, for example, the average age of marriage is only 15 years. The number of children that a woman will have in her life is between 4 and 5 on average, and almost 50% of women will lose at least one of their children in their life. So, again, so we've kind of started with these quantitative measures, but when we really thought about it, we wanted to focus on data that we could present in a really visual way, in addition to picking data that we could use in conjunction with some educational points. So what we did is we settled on a really pictogram type method of visual aid. So we took these little figurines, both men and pregnant women, and painted them and cut them out and had them laminated so that we could paste them, put them on and off of a poster board pretty easily. So as an example, another statistic that we shared with the communities was that their child mortality was around 20%. So to illustrate this, we took, you can see on the left, 4 pictures of healthy-looking children, and then 1 picture which you can't really see, which is actually of a coffin. And another example is for the cause of death, we took a picture of a mosquito to represent malaria, and then 2 other pictures to represent respiratory illness and diarrheal illness. And so in one community that had, let's say, 20% of those of that child mortality was coming from malaria, we would put 2 of the figurines or 2 of the figures under the mosquito, and we'd put 1 figure under the respiratory illness, and so on. So just some more examples. This question on the left asked the women, when your child has diarrhea, do you give them less fluid, the same amount of fluid, or more fluid? And about 50% of the women responded to that question that they give their child less fluid when he or she has diarrhea. So we represented that by putting about half of the little guys next to the empty glass and about half of them next to the half full glass. And as you can imagine, this was a good jumping off point for some educational points about oral rehydration therapy and the importance of providing their children with plenty of fluids when they have diarrhea. So we did kind of the same thing for the statistic of the number of women who give birth at home versus at a healthcare facility, which, as we mentioned, is really a focus of the traditional birth attendant program. And because we could take these figures on and off, what we would do is we'd start off by presenting the actual statistic for the community, and then say, but what's really going to be healthiest for you and for your children is if all of the women are giving birth at the hospital, and then we take all of the women and bring them down under the picture of the hospital. So we use the same figures to talk about antenatal care as well, and this was a good example actually of a lot of variation amongst the communities. So one community might have 20% of the women who received 1 visit of antenatal care, and so we would compare that to the other communities and say, listen, this community that's really not that far from you and is similarly isolated in terms of healthcare facilities, they're getting 70% of their women with at least 1 antenatal care visit. So that was another method we used. And so the last concept that we really tried to tackle was contraception. And as you can see, the fact that only 5% of the women were currently using contraception, while 20% said that they didn't want more children in the future, demonstrates really an unmet need for contraception. And so this issue really illustrated one of the biggest challenges for us, and that was not just presenting the data in this quantitative way that's accessible to the audience, but really trying to engage them in a discussion. And this was hard, but we did 6 of these presentations total, and I think that with each one we were really more successful in achieving that goal. And I think we talked about some really interesting things came up. Like we talked about the women mentioned that they have to hide their contraceptive methods from their husbands sometimes, and I think some of the men said that if they use contraception with their first wife but not with their second wife, then the first wife becomes jealous and they have problems with the family. So things like that. And just from my point of view, it was actually really pretty exciting to help foster these discussions that were difficult but also very important, and that I really don't think would have happened otherwise. So on that note, I'll hand this over to Alina, who will talk more about the TBA program.
So the traditional birth attendant program was a program that was launched in response to some of these statistics that we learned from the survey. And this was the project that I worked with closest during the summer. And the idea behind the traditional birth attendant program was to work to reduce some of the maternal and child mortality that we noticed in these communities by taking women from the rural communities and training them to be health advocates and health educators. So while these women wouldn't be able to provide actual medical care, they could educate their community members about really important topics like how to prevent certain diseases, what are the danger signs of a pregnant woman, somebody giving birth, or in a newborn, what are proper immunization schedules. And also, really importantly, one of our kind of key focus areas is they could help encourage women to go give birth in health facilities rather than at home in the safest setting possible. So in 2011, we had the first class of matronas, and these were the traditional birth attendants. There were 30 matronas, 6 women from 5 different communities that received a week-long training in the Gorongosa National Park Education Center. And these women were chosen because they were already doing similar sort of work in their communities. They were acting as kind of wise women, so were respected vehicles for spreading this kind of information, health information within these communities. They received a week-long training and then were followed by monthly supervision visits by our local staff. And here are 2 crucial staff members here. One of them was Senor Pino, who's a nurse who provided training along the more clinical grounds with the women, whereas Pelagia focused more on income-generating work that the women were doing to supplement their traditional birth attendant activities and help support them in this work. Now, in 2012, our summer in Mozambique, we held a week-long refresher training for the matronas. And so there were 33 traditional birth attendants from 6 communities. This time we added another community. And they covered same topics as they had covered during the initial training, so including things like hygiene, family planning, prenatal care, newborn care, HIV, STI transmission, you can see here. But also extended the training to new topics that we wanted to focus on, including gender-based violence, environmental conservation, and nutrition of certain local plants. Another really important aspect of this training was implementing a data collection system. So one of the challenges of working with a population that's this rural and also non-literate is that it's really hard to gather data to evaluate the program to see what its impact is like. So a non-literate data collection form was developed where the TBAs could literally mark off how many women they talked to and also what were the actions that the women took, like whether or not women gave birth at home, whether or not they had antenatal visits, whether or not they used mosquito nets, and so could allow us to measure impact without going through the enormous effort of survey collection like we did for the baseline data survey. And we just received, so these forms were launched this summer, and we just received our first quarterly kind of data information that kind of gives us really promising and exciting news about the program so far. So far, almost 4,000 individuals were reached by these TBAs and educated on key prevention messages. So things like HIV transmission, like, care of a newborn, like hygiene, like vaccines. The TBAs supported 367 pregnant women, of which during this quarter, 111 gave birth. And of these women that gave birth, 44% gave birth in a health facility. Whereas if you remember, only 16% were giving birth in a health facility according to the baseline data. And we can't attribute this entire jump in this entire growth in healthcare facility births to the TBA program alone, but it does show a really promising trajectory. Finally, a big part of this training was expanding the scope of income-generating activities that the women were able to do. And this is something that Michelle will talk about in a little bit more detail. But the importance of these programs is because we can't pay a wage to the traditional birth attendants, giving them a craft that they can sell to supplement their work, helps them do the traditional birth attendant activities. And also because due to this program, by participating, they're doing something that's bringing in cash into the household. It allows their husbands to see that they're doing work, and actually allows their husbands to let them go and continue on this work. So I'm going to let Michelle explain more details of this.
I'm going to take a little pulpit liberty here to tell you how amazing this group of students was in action and the dedication that they put in this past summer. And I'm sure the students who came in the summers before I was there put in the same level of work, but I got to see this firsthand. And also to Sigrid and Anu, who have created a partnership with these communities that I think will last for the entire lifetime of this program. I'm proud to be a colleague, and I was extremely proud to participate. Also want to shout out to Karina, who is here, who is our EcoHealth Program Director. Karina's role is based in Mozambique. It's the rainy season now, so she's here on holiday. Welcome. I'm so glad you made it to join us. All right. So as Alina described, my role was to help. Since we had created this income-generating program, my role was to help set up an administrative structure, since we would now have products and services that these women would be providing, so to create some kind of system to track and understand how the financial modeling would be appropriate. Also to try to do some professional development, because as you've heard, these people in these communities are under-resourced, and the educational system is not in their reach, and so the majority of these women are undereducated. This is a picture here of Pelagia, who is our program coordinator, and Donna Dupuy, who's a woman who came and helped us. We tried to conceive this project so that we could give women the opportunity to generate income for themselves and to sustain the program. We received funding from Bristol Myers Squibb to establish the program, and with these funds, we hired a seamstress to come in and train Pelagia, who you see here with the braids, to train the traditional birth attendants in sewing techniques. We thought that it was a great idea for them to create something that would be sustainable for their communities, and also with materials that would be easily accessed locally. So what we did was we decided that the women would sew placemats from the capulanas, which are the materials that are used, the fabrics that are used on their head wrap, also to carry their babies, also as skirts. So these fabrics are found all over those communities, and the women, it's readily available. Last year, we produced an inventory of placemats. We have some of our placemats here for sale. And the proceeds from the sale of the placemats goes back to pay the TBAs for their work, and also to invest in continuing the program development and continuing the production of these items. And as the growth of the program continues, we had to begin tracking supplies. We now had inventory. We had to figure out how to market these products. We had to figure out how to sell them, what supplies were needed. And these were skills and issues that had not really been put forth especially for Pelagia, who had traditionally been the communicator and interpreter for the programs. So we created a budget. We understood how much product was being made, at what time frame, what supplies would be needed. We tracked that information, and we created a grid and a structure for her to be able to do that. Also, last year, we were able to increase our product offerings. We started with placemats. Last year, we expanded our products. We now have gift bags, wine bags, and/or toiletry and/or makeup bags, coasters, and travel bags, along with the placemats also for sale. And so because we had now different product lines, we were able to establish a relationship with the gift shop at the Gorongosa National Park. So whereas our first batch of supplies and products, we were traveling back and forth from Africa to the US in order to sell them, we've established relationships now with gift shops at the national park, so that the products are now being readily available to people who come and visit that region on their vacation and holidays. In addition to my role in setting up the tracking marketing expense process, I was also there to help serve as a mentor and to help develop some of the staff, specifically Pelagia, in her expanding role. That part for me was extremely gratifying, not to mention the work that that we do there, and I was extremely proud to be there and provide some mentorship in some areas that I feel that I have quite a bit of strength in and that we know that we need in that region. It was really an amazing, transformative experience for me. So, can I just tell you about this elephant? I know I'm taking liberties. I'm on time, though. This elephant, she was magnificent and beautiful, and I was as close as you are sitting to her right now. It's beautiful. She was actually mad at us. I didn't know that at the time. I just thought she was being cute by flicking her ears, but that was a sign of aggression. So I found that to be one of my favorite pictures. Next steps. So now we've expanded our offerings. We're trying to now expand our opportunities to sell our products. We've realized that Pelagia is probably not the person to grow this operation, that her skill set, that she is exercising her skill set and doing exactly what she was doing before I got there, and that what we need now is to have somebody train a trainer so that someone there can oversee the administrative operation of this program and to really grow it. As you can see, we've created quite a bit of inventory and lots of stock, so now it's time to take it to the next level. Also, the program needs support, financial support, administrative support, developmental support, and so that's going to be the next steps as to where we're going to take the program from there. Thanks. Alex?
As one of many elephants we saw, no trip to Mozambique or Gorongosa is complete without learning how to recognize when an elephant is angry. Anyway, I'm going to talk briefly to you about the Agente Polivalente Alimentares program, which roughly translates to community health worker. This is a national Mozambican program that's sponsored by the Ministry of Health throughout Mozambique and aims to bolster access to healthcare workers throughout Mozambique in many of the different provinces and remote villages, and to improve health outcomes, improve education and literacy. And so in the Gorongosa district, our eco-health program partnered with the Mozambique Ministry of Health to support the APE training in the villages in the Gorongosa region. So the goals of the APE program is multifaceted. The first is to place permanent health workers in the villages, and these are young adults who have come from the communities, have trained as APEs, and I'll talk about that in a minute, and then they go back to their communities and serve in their communities. So it's really not bringing anyone else new in, but taking people from the community, training them, bringing them to a higher level of health education and literacy, and bring them back to the communities they can serve there. They also serve as health educators to promote health in the villages. They assist with some of the mobile clinics that are run on a monthly basis that are often crowded, and they help to you can see that as Anu and I are trying to weigh a baby on the scale there, and it's a very crowded environment. So having the APEs there and additional health workers to help improve the efficiency and efficacy of the clinics will be a big improvement. And hopefully they're not currently trained to give vaccines, but hopefully that's something that now they've got a baseline level of health literacy they might be able to do in the future, because again, these are areas of the mobile clinics where things get backed up, and you've got Anu helping out here, and one of the nurses, Sergio, giving clinics to lots of young children. Giving vaccines to young children at the mobile clinics. So how do you become an APE? It's a rigorous training process. Involves, for the program in Gorongosa, 13 different villages, six of which were our eco-health villages, would select 1 or 2 students from each of those communities and send them to the program. It's a 5-month course that went on in the main sort of town center, and it was a rigorous program. So there were 23 of the 24 students graduated. 1 of them did fail. But by the end of the program, the expectation and the hope is that they have an extensive skill set to diagnose and treat and be health managers in these villages. So this is a picture of their sort of health kit, their doctor's bag per se. And it's pretty full. It's got sort of extensive first aid supplies, non-adhesive, lots of non-adhesive pads, bandages, antiseptic, gauze, rapid malaria tests, antimalarials, antibiotics, analgesics, mebendazole, oral rehydration salts, condoms, soap, matches, a full sort of kit to do a lot of good outreach in the villages. And to help identify, the other role they would have was to identify when people were sick beyond their skill set and to really manage health in the villages. And so their training culminated with this field rotation. It was a 2 to 3 week field rotation where a group of APEs would, hit a button there, a group of APEs would go out to the village and sort of work on teaching, going from dwelling to dwelling, teaching about clean water. They were digging latrines and teaching about clean use of bathrooms, identifying sick patients and sick village goers. And here in this picture, this is a little cut off. You can't see the individual here. This young boy who had fallen off his bike and injured his leg. And this is one of the nurse trainers and teaching about basic splinting skills and helping to stabilize his leg before he was taken to the hospital. This was a really cool moment for me. I have a background in wilderness medicine, and I did sort of a lot of impromptu splints and stuff. And after this, we sat down with all of them and sort of talked about the basic principles of splinting a joint, splinting a long bone, and how they would do that. And it was really cool to see how far they'd come and how much they'd learned. And at the end of this, there was a very sort of a big graduation. There were prizes given. There was sort of a best student. There was a student who was selected by all of their peers to win a prize. The governor came, and this was a very big deal. Lots of hurrah. There was lots of dancing. And for me, you know, this is a 5-month program, and we were only there for 8 weeks, so we really sort of got a chance to bear witness to the end of the APE training and sort of the graduation to see the very end. And for me, it was really an aha moment in this experience. When we first got to Mozambique, and you're in a very remote area, some of the questions that come up is sort of, what are we doing here? What impact are we going to have? You see, you know, dire poverty, and you don't have a chance. You sort of think, you know, what am I doing? What can we do? But what I saw here with the APEs was an incredible amount of pride. We saw them in the villages. Some of them were children of the Matronas that Alina was talking about. And as they danced and as they saw the governor, they really took pride in this new role, in this empowering role that they would then serve in their communities. And for me, what was powerful about that was I realized that, you know, we're not going to build a new Mount Sinai or another hospital in Mozambique tomorrow, but that these villages now have a community health worker who can offer some sort of basic health care in their villages, can manage care, can educate. And moving forward, that's a huge step, and that's sort of a groundbreaking step for this remote area, because though we won't have a Mount Sinai there tomorrow or a hospital there tomorrow, the APEs are there now. They've got a little bit more money, they've got bikes, they've got a level of literacy. Maybe their children will be nurses, maybe their children's children will be doctors. And that was a real powerful moment for me in the experience, and a really humbling way to think about how global health can happen. So with that, I think that's the end. Are there any questions for anyone here? Thank you so much for your time and attention.